vitreous hemorrhage. You know the anatomy of the vitreous. It is 99% is water, 1% collagen and hyaluronic acid, and the space represents 80% of the eye and has a volume of about 4 milliliter, firmly attached to the retina at the vitreous base, followed by the optic nerve and retinal vasculature. You know vitreous hemorrhage had the incidence of 7 cases per 100,000, which makes it one of the most common causes of acutely or subacutely decreased vision. Although the diagnosis of vitreous hemorrhage is generally straightforward, management is directed by uncovering the underlying etiology. The mechanism of vitreous hemorrhage: it may be abnormal blood vessels that are prone to rupture, normal vessels that rupture under stress, or extension of blood from the adjacent source. The abnormal vessels, either due to ischemia, retinal ischemia leads to release of vascular endothelial growth factor and other chemotactic factors resulting in new vascularization, and the mechanism of rupture is lack of tight junctions, coexisting fibrous components which contract, or normal vitreous traction with eye movement. Examples of causes of new vascularization is proliferative diabetic retinopathy, central retinal vein occlusion, branch retinal vein occlusion, sickle cell retinopathy, retinopathy of prematurity, ocular ischemic syndrome, and the normal vessels that rupture under stress is hemorrhagic BVD, blunt or perforating glaucoma, and there is also Terson syndrome, which is a rare cause of vitreous hemorrhage. In Terson syndrome, which refers to an extravasation of blood into the vitreous due to a subarachnoid hemorrhage, the blood is not an extension of the subarachnoid hemorrhage. Rather than sudden increase in the intracranial pressure, it can cause the retinal venules to rupture. Extension of blood from adjacent source may be due to macroaneurysm, hemorrhagic disciform scar, and signs and symptoms of vitreous hemorrhage is floaters and or visual loss, vision worse in the morning. Detailed history is essential. Complete examination plus or minus %. How it looks like: red cells dispersed behind the lens, subhyaloid or pre-retinal hemorrhage. Dispersed vitreous hemorrhage into the body of the vitreous has no defined border and can range from a few small distinct red blood cells to total obscuration of the posterior pole, organized vitreous hemorrhage. The natural history: the blood is typically cleared from within the vitreous hemorrhage at the rate of approximately 1% per day. Vitreous hemorrhage is cleared more quickly in sclerotic and vitrectomatized eye, more slowly in younger eyes with well-formed vitreous. The natural history of vitreous hemorrhage depends on the underlying etiology, with the worst prognosis for diabetics and AMD patients. Complication may be hemosiderosis bulbi, proliferative vitreoretinopathy, gauze cell glaucoma, hemolytic glaucoma. Treatment is observation for the hope of spontaneous resolution, then treatment of the cause. Vitrectomy is also indicated for non-clearing vitreous hemorrhage, new vascularization of the iris and or the angle, or gauze cell glaucoma. Timing of the vitrectomy depends on the underlying etiology. New therapies such as intravitreal injection of hyaluronidase are currently being studied and may provide additional treatment options in the future. Timing of the vitrectomy: it is urgent in retinal detachment and iris or angle new vessels. In cases of type 1 diabetes, it may be up to 1 month, subhyaloid vitreous hemorrhage 1 month, type 2 diabetes 2 or 3 months, other causes 3 months or more. And thank you.